Hello, we're glad you joined us for this live webinar, The Importance of Procalcitonin for Antimicrobial Stewardship in Patients with Lower Respiratory Tract Infections in the Emergency Department. I am Michelle Ashton of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, a leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by Biography. A world leader in the field of in vitro diagnostics for over 55 years, Biography is present in 43 countries and serves more than 160 countries with the support of a large network of distributors. Biography provides diagnostic solutions, systems, reagents, software, and services which determine the source of disease and contamination to improve patient health and ensure consumer safety. Its products are mainly used for diagnosing infectious diseases and some critical illnesses. The company's diagnostic solutions are also used for detecting microorganisms in agri-food, pharmaceutical, and cosmetic products. To learn more, please visit biomiriu.com. Now let's get started. You can post questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click on the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of the presentation window. If you experience technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of the presentation window, or report your problem by typing it into the Ask a Question box located on the far left of your screen. This is an educational webinar and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, John Boreyko, the co-director of Antimicrobial Stewardship Program and a Clinical Infectious Diseases Pharmacist at Duke Regional Hospital in Durham, North Carolina. He received his Doctorate of Pharmacy at the University of North Carolina at Chapel Hill and is a board-certified infectious disease pharmacist. He has been utilizing biomarkers and diagnostics for almost 10 years and spearheaded the implantation and education at his hospital. Dr. Boreyko will now begin his presentation.
Good morning, and thank you, Michelle. Also, thank you to Biomiriu for sponsoring this webinar and for their constant dedication to improving antibiotic stewardship worldwide. As Michelle said, we're going to talk about the importance of procalcitonin for antibiotic stewardship, mainly in patients with lower respiratory tract infections in the emergency department. My disclosure, I do receive honoraria and a consulting fee from Biomiriu, Inc. for advisory and consultation. Our objectives, we're going to gain a better understanding of how procalcitonin can aid in the diagnosis of lower respiratory tract infections. We will also try to understand how procalcitonin may aid the emergency room clinician in deciding whether to initiate antimicrobial therapy. So again, we will explore how using a procalcitonin-driven protocol in the emergency room can aid the clinician in deciding whether to initiate antimicrobial therapy. We're also going to look at the existing data, mainly from a safety aspect and from decreasing antibiotic use without adverse reactions, using a procalcitonin in patients with presumed LRTIs, and how antibiotic stewardship programs can use this biomarker in shaping their clinical decisions. And lastly, we will try to examine what stewardship metrics may be impacted by using a procalcitonin-guided protocol. So my practice is at Duke Regional Hospital. We are a 369-bed community hospital, but we're also an academic teaching hospital affiliated with the Duke University Health System. Our emergency room is quite busy. We had in 2018 almost 70,000 visits, and we are about 6 months into a significant expansion of both our emergency room and psychiatric services. So those numbers will obviously go up. So let's start with a patient case and an antibiotic question. So we have a 50-year-old female who presents with increasing sputum production and shortness of breath. Her vital signs are basically within normal limits. Her calculated Curve 65 score is 0. Her past medical history is significant for hypertension, type 2 diabetes, which is diet controlled, COPD, and osteoarthritis. Her social history, 4 to 5 glasses of wine per week, and a 20-pack year history of smoking. Current medications: lisinopril 20 milligrams daily, PRN Motrin for her osteoarthritis, and a PRN albuterol inhaler. She was given a stat albuterol nebulizing treatment and 125 milligrams of methylprednisolone in the emergency room. Her chest x-ray reveals a mildly hyperinflated lung with no discernible infiltrates. She's placed on 2 liters of oxygen via nasocannula. Her measured procalcitonin, which was ordered stat, resulted in a value of less than 0.1 nanograms per ml. Sputum sample obtained and sent to the lab for gram stain and culture, and since the patient was not decompensated, we did not obtain blood cultures. So, would you initiate ceftriaxone azithromycin for presumed CAP? Would you initiate moxifloxacin for a presumed respiratory infection? Would you initiate azithromycin for an acute exacerbation of COPD? Or would you recommend no antimicrobial therapy? And at the end of the presentation, we will circle back to this. So, CDC in 2012 looked at the burden of antibiotic use in emergency rooms, outpatient clinics, and physician offices. And the good news is 70% of the prescriptions were necessary, but when they did a sub-analysis, right drug at the right dose for the appropriate length of therapy was lacking. 30% were unnecessary prescriptions, and their goal by 2020 is to reduce inappropriate antibiotic use by 50%. The burden of antibiotic use in the hospital setting is not much better. In this country, the CDC estimates that 2 million patients will acquire an infection while hospitalized, resulting in 90,000 deaths. Worldwide, it's not much better, with an estimate of up to 700,000 deaths from a hospital-acquired multi-drug resistant organism. And studies have shown that 20 to 50% of antibiotics prescribed in U.S. acute care hospitals are unnecessary or inappropriate. Hopefully this slide shows up a little bit better, but this is a CDC look at E. coli resistance in the United States. In 1999, they started collecting this data. The green line is aminopenicillins, which would be your amoxicillin and your augmentins of the world. And you can see that as of 1999, they were almost basically resistant. Whenever you exceed that 20% threshold, antibiotic resistance is understood. Quinolones are the pink line, and by 2004, we were already approaching that 20% resistance, and we peaked in 2012 at almost 35%. Of course, this didn't help. In 1995, the FDA approved using Cipro in poultry and farm animals to reduce infection. So that does not help as far as breeding drug-resistant mutations that can possibly be transmitted to humans. Luckily, in June 2015, the Joint Commission on the Accreditation of Healthcare Organizations developed antibiotic stewardship standards with an implementation of January 1st of 2017. So that might account for plateauing of drug resistance around 2012. So hopefully we will continue on that quest. So let's examine procalcitonin. We know it's produced in C cells of the thyroid gland. It produces in the presence of the bacterial infection. Procalcitonin is uploaded by exposure to endotoxins and cytotoxins. We know that concentrations greater than 0.25 nanograms per mil encourage antibiotic use, and that studies have shown levels greater than 2 nanograms per mil significantly increases risk of mortality. Bacterial infections, again, secrete interleukins, TNF-alphas, which upload procalcitonin production, whereas a viral illness would have gamma interferon secretion, which actually suppresses procalcitonin. Let's look at procalcitonin against other biomarkers. We already talked about TNF-alpha and the various interleukins. They do peak very quickly in the presence of a bacterial infection, but then come down very quickly. So if your patient failed to present to the emergency room in a timely fashion, he or she may have already peaked, and then the decrease may have started. CRP in the light blue line starts peaking at around 6 hours, and then goes for about 18 to 30 hours before it plateaus out. Procalcitonin in the yellow line starts to peak around 2 hours from the bacterial insult, and then over the next 24 hours will increase to its maximum level. And then because of the half-life of 24 hours, you would expect with appropriate antibiotic therapy and identification of the source of infection that the procalcitonin should start its decline towards 48 hours. Another slide for understanding procalcitonin kinetics. Again, it usually rises anywhere from 3 to 6 hours after a bacterial infection. It's not consistent in every patient, so your patient may present immediately to the emergency room, but may be slow to respond to the bacterial insult. In that case, if your initial procalcitonin was negative, but you have a clear clinical suspicion that he or she may have a bacterial infection, then you can certainly repeat procalcitonin within 4 to 6 hours and see if they do have that increase that you would have expected. Again, it peaks usually between 12 and 24 hours with a half-life of about 24 hours. Procalcitonin production and serum concentrations will decrease by 50% per day with appropriate antibiotic treatment. If your second procalcitonin level does not decrease by 50%, or if it remains the same or increases, then you have to double check your antimicrobial regimen and make sure it's appropriate, or maybe search for a different source of infection that you may be missing. And if antibiotic therapy is inadequate, again, procalcitonin levels will remain high. So, is procalcitonin effective in stewardship teams? We know that we're asking clinicians to either withhold antibiotics or to stop antibiotics early. And of course, their chief concern is going to be, is this going to result in adverse outcomes for my patient? Luckily, at our hospital, stewardship has been going for almost 10 years. So our physician staff trusted antibiotic stewardship and realized that when you decrease antibiotic exposure, there are better patient outcomes. So Dr. Schutz and company did a meta-analysis. It was basically an update of a 2012 Cochrane review, which was to look at the safety of a procalcitonin guided for antibiotic stewardship. Their objective was to assess the safety and efficacy of using procalcitonin for either starting or stopping antibiotics over a large range of patients with varying severities of acute respiratory infections and from different clinical settings. So it was a randomized trial. You either got the controlled, which was standard of care without a procalcitonin guided regimen, or the intervention group, which was procalcitonin-guided antibiotic treatment. Primary outcome was all-cause mortality, also treatment failure at 30 days. His secondary outcomes were antibiotic use, antibiotic-related side effects, and length of stay. So his results were significant from a statistical standpoint. He showed a 30% reduction in mean time on antibiotics in the procalcitonin-guided group. And that grade quality of evidence was very high. He also looked at 30-day mortality, which was the other primary outcome, and there was a decrease in the procalcitonin group. That was also a grade quality evidence of high. As far as the secondary outcomes, there was again a 2.4-day decrease in antibiotic exposure with a quality of evidence high, and the risk of antibiotic adverse drug effects was quality of evidence moderate. Length of stay and ICU were similar. So the summary of Dr. Schutz's Cochrane review was that a procalcitonin-guided protocol does decrease antibiotic exposure, does decrease antibiotic-associated adverse reactions without increasing mortality across all settings and all types of acute respiratory infections. Dr. Broyles from Arkansas, he also did a single center test. Again, very similar to Dr. Schutz. It was a single center retrospective cohort. He had over 2,100 patients. He took patients from all settings, so critical care and acute care. And he did a pre and a post. So he took data from 4 years prior to procalcitonin implementation, and then he had a washout period, and then he took data from 4 years after a procalcitonin implementation. His primary endpoint was median days of therapy. His secondary endpoints were pretty vast: hospital mortality, 30-day readmission, Clostridium difficile infection, and adverse drug events during hospitalization. He showed a statistically significant reduction in days of therapy when you followed a procalcitonin protocol. For his secondary outcomes, 30-day and antibiotic-associated adverse drug effects, a 50% reduction, a reduction in hospital mortality, and a reduction in C. difficile infection. So we have more studies that are more contemporary. One of the knocks on procalcitonin was that all the initial studies were done in Europe and Asia and not necessarily in America, but with Dr. Broyles' study, that sort of paved the way for other studies that are occurring in the United States. So Dr. Jennifer Townsend out of Hopkins, she did a great study. It was a single center, controlled pre and post interventional study in patients admitted with LRTIs. She had 374 patients, 174 in the procalcitonin or intervention group, and 200 in the control group, which was just usual care. Her primary outcome was median antibiotic duration, and her results were a 1-day decrease in antibiotic duration. Now, I applaud Dr. Townsend because when you look at her inclusion criteria, she took pneumonia patients and COPD patients. This was not a low acuity group. Her pneumonia patients, 47% of them had a curve 65 of 2 or greater, and her COPD patients, 41% were graded at either severe or very severe. So this was a moderate to high acuity patient population, and she still showed a 1-day decrease in antibiotic consumption. Most importantly, she involved an antibiotic stewardship team along with the procalcitonin level to drive this study. Antibiotic adverse drug events, there was no difference. And she had a robust adherence of about 70%. Dr. Angela Branch out of Rochester, she did an open label randomized clinical trial. It was a 1-to-1 randomization. And interestingly enough, she compared procalcitonin plus a viral PCR, compared it to standard of care. Her primary outcome was antibiotic exposure and then also safety at 30 and 90 days. She had 300 patients, 151 in the intervention or procalcitonin group and 149 in the control or the usual care. She did have some CAP patients, but they were very small in number. They did exclude anybody with a positive infiltrate. And she showed a decrease in antibiotic consumption by 2 full days. This was a study-driven event, so there was no antibiotic stewardship involved. Again, she showed no difference in antibiotic adverse drug events, and her adherence was 64%. Now, it did differ a little bit. This particular study with Dr. Branch and colleagues, they really favored a lower acuity level where the adherence was a little better and that decrease in days of therapy was more. The higher the procalcitonin and the greater the acuity, I think they were closer to decreasing antibiotic consumption by 1 day. And lastly, we have the PROACT trial. That was Dr. Wang and colleagues. This was a trial that sort of made stewardship teams sit back and say, wow, because this was the first test in over a decade that showed that there was no difference in decreased use of antibiotics using a procalcitonin protocol. So they had 1,656 patients, 826 in the procalcitonin group, 830 in the standard of care. Majority of their patients were low acuity LRTI, so exacerbations of asthma and bronchitis. And again, they showed no decrease in days of therapy of antibiotics. They did not have an antibiotic stewardship team involved. As a matter of fact, the 14 universities that were part of the study did not use procalcitonin as part of their usual care. So there was no difference in antibiotic adverse drug reactions. Their adherence for their CAP patients was 39%, and for their non-CAP patients, 65%. This PROACT trial actually reinforced my belief in procalcitonin because it's not just a number. You can't just give a number to a physician and say, this is it. I want you to stop antibiotics. I want you to withhold antibiotics. Procalcitonin, when it's paired with an antibiotic stewardship team and physician trust, is a valuable tool in deciding whether or not to initiate or discontinue antibiotics. So there are some other biomarkers of infection we mentioned in a previous slide, CRP. It is an inflammatory biomarker, including the respiratory tract, but unfortunately there's many other disease states that will also cause an elevation in CRP. It's associated with reduced antibiotic prescribing for respiratory infections, and that was a 2013 meta-analysis. The issue is it has very high sensitivity, but only with levels greater than 6 mg per liter. And unfortunately, it does not differentiate between bacterial infection and viral illness. And it is unspecific, but again, we really don't use it too much in respiratory infections at this time. So at our hospital, there are obviously procalcitonin limitations. We know the limitations include end-stage renal disease, renal cell carcinoma, thyroid cancers, and severe burns and trauma. But we actually know that there are some relative limitations that patients with CKD3 and CKD4, and also patients with AKI and non-small cell lung cancer with or without lobectomy may also have an elevated procalcitonin in the absence of an infection. We actually did a one-year study. It was part of a project of one of our pharmacy residents, Dr. Andrew Darko, and he did a great job, and he did see that in CKD3 and CKD4 patients that there was an elevation in procalcitonin levels. Now, this is a great segue into what stewardship teams probably need to do. They need to not ignore end-stage renal disease or CKD patients and maybe start getting Procal levels so they can get a baseline. There is anecdotal information out there that an end-stage renal disease patient that's not infected has a baseline Procal of 0.5 nanograms per ml. But it's sort of a moot point because when your end-stage renal patient comes into your emergency room with fevers, they have a dialysis catheter, guess what? They're going to get vanc and Zosyn. Doesn't matter. Procal may allow you to de-escalate quicker, but you have to preserve the dialysis catheter at all costs. But based on Dr. Darko's research, we did educate our physicians that yes, we can use Procal in CKD3 and CKD4, but we're going to use that as part of our assessment. So justifying procalcitonin at Duke Regional Hospital. Well, we use it at our hospital in the emergency room as a test of exclusion in patients with presumed LRTIs. We also use it as a baseline value in patients with presumed sepsis. In our ICU settings or internal medicine patients, we will use it as a guide to de-escalate antibiotics in culture-negative patients. So you come in, you have an acute exacerbation of an LRTI, we will get one procalcitonin level, and if that's negative, and then combine that with clinical decision-making of the physician, we will decide whether or not we're going to admit or send home, and whether or not we're going to give antibiotics or not antibiotics. Again, in the emergency room where everything starts, if that patient is septic, we will get a baseline and use that, and then we will order subsequent procalcitonins on day 2 and 3 to make sure that we're getting that 50% reduction. And we know that on day 3, if the Procal is 80% of what it was on day 1 in a culture-negative patient, you could decide to maybe start to de-escalate antibiotics. So I had to justify Procal before we even had it in our hospital. So management wanted me to look at all of these exacerbations of LRTIs. So what we did was we did back then an ICD-9 code, and we looked at everything for exacerbation of asthma, bronchitis, or COPD. And when we excluded our patients, included not admitted, we had 710 patients. 497 received the antibiotics, 77 did not. You can make the argument that the 77 patients who didn't get antibiotics weren't as sick as the ones who did, but I can make the argument that because they had an exacerbation of an LRTI, that it's just part of our culture that we have to give antibiotics. So our methods are antibiotic use versus no antibiotic use. So we already had those 2 cohorts. Our primary outcome was length of stay. Our secondary outcome was 30 and 60-day same cause readmission or C. diff infections, or a C. diff infection that was obtained within our hospital. And we showed a 1.4 reduction in the length of stay between the antibiotic group and the no antibiotic group. And at the same time, Dr. Musher and group in the New England Journal of Medicine released his findings on the CAP guidelines. And for the first time ever, procalcitonin was included in all aspects of CAP. Basically, whether or not you include antibiotics based on the procalcitonin level or whether you withhold based on the procalcitonin level. And that was at about the time when the Vitas Brahms procalcitonin got FDA approval for both aiding in the diagnosis of LRTIs and also for de-escalation in severe sepsis. So Duke Regional procalcitonin implementation. We are basically using the same algorithm that most hospitals in this country are doing. We set this card up in our emergency room. And again, if you look at algorithm number 1, if your procal is less than 0.1, antibiotics are strongly discouraged. If it's 0.1 to 0.24, antibiotics are discouraged. If it's greater than 0.25 but less than 0.5, antibiotics are encouraged. And if it's greater than 0.5, it's like definitely start antibiotic therapy. And this is our algorithm for severe sepsis. That's just there for your edification. Again, we do use it in our severe sepsis patients. And of course, the values are higher. Some of the studies that showed no change in mortality had unrealistic expectations where they wanted the procal to be less than 0.1. So as you can see here, that the threshold starts at 0.25, and as far as de-escalation, it's much higher than what you would expect in LRTI patients. So they weren't done with me. So once we got procalcitonin into our hospital, they wanted me to do another study. So we were going to examine the role of procalcitonin guided in reducing antibiotic initiation versus the standard of care. And we were going to compare 30-day readmission rates for same-cause admission. So what we did was a retrospective chart review. We just did a 5-month snapshot. So our inclusion criteria was from January to May of 2016. Anybody who presented with shortness of breath and or increase in speed and production, and you needed a procalcitonin level that was drawn within 24 hours, and it had to be less than 0.25 nanograms per ml. We excluded the usual age under 18, pregnancy, and prisoners. We did exclude kidney disorders, including end-stage, CKD 3-4, AKI, or renal cell carcinoma. And we also excluded non-small cell lung cancer and lobectomies. We collected procalcitonin levels. We looked at the percent of patients that received antibiotics, and we looked at 30-day same-cause readmission rates. We compared patients with the same-cause diagnosis codes prior to the implementation and the percent of patients who received antibiotics. So in the pre-procalcitonin cohort, we had 574 patients. 87% received antibiotics. A 30-day same-cause readmission was 5.2%. In the procalcitonin cohort, and it was 470, so fairly robust for just a 5-month snapshot. 53% received antibiotics, and our 30-day same-cause readmission was 0.4%. So our conclusion, use of a procalcitonin-guided protocol resulted in a 34% decrease in antibiotic initiation, and use of a procalcitonin-guided protocol resulted in a 93% reduction for same-cause readmissions. Now, this was fairly early into our procalcitonin era. My guess is if I repeated the same exact study, that I would hope that that 34% decrease in antibiotics would be higher, maybe 50 to 60%. As far as 93% reduction for same-cause readmissions. I don't have an explanation for that. The only difference between the two groups was receiving antibiotics. I would not expect to have 93% reduction again, but I think if you told your C-suite that you can reduce same-cause readmission by 50%, they would be quite happy. So we do have a pending study, or at least it's under IRB evaluation right now. Hopefully we will get IRB approval by end of July and start collecting data September 1st. We're basically any patient presenting to the emergency room for an acute shortness of breath who have an ordered procalcitonin level. We're going to measure adherence to the procalcitonin guided protocol. We're going to stratify procalcitonin values and compare the percentage of antibiotic prescriptions. So basically, we're going to look at the 4 different boxed categories of Procal and see at which point antibiotics were prescribed more often, in other words, higher acuity levels. We're going to assess the accuracy of procalcitonin. So we always measure it against what we grew, and we'll assess 30-day same-cause readmission rates between each cohort. So implementation pearls. You've got to include all aspects of our emergency room in this decision. You need to talk to the emergency room doctors and nurse practitioners and physician's assistants. You need to talk to the CMO. They need to be totally, absolutely involved in this protocol. You need to educate. You need to continue to educate all the time. When we started it in our emergency room, I was there 2 or 3 times a day, looking at the log, looking at the different admitting diagnoses, and recommending procalcitonin levels in these patients. We reinforced the protocol in person and easily findable information cards. We had a continued presence for the first month or 2, and we made sure that our emergency room pharmacist was well disciplined and educated as far as the use of procalcitonin. You've got to give your emergency room the data so they can see the potential that procalcitonin may have for their patients and their department. And procalcitonin absolutely has to be actionable. That means it can't just sit in a computer database and the clinician not be able to see it. So that's a big decision for your hospital. Are you going to put it in the chemistry lab, or are you going to put it in the micro lab? We chose the chemistry lab because it was a 24/7 facility. If your hospital's micro lab turns the lights off at 11 o'clock and doesn't turn them on again until 7 a.m., then you probably want to put that procalcitonin device in the chemistry lab. We also run our procalcitonin off the chemistry tubes anyway, so when the emergency room draws that tube of blood, it goes to the chemistry lab, they do their thing, and then they transfer it to the procalcitonin machine, and then they get that level. If for some reason you choose to do the procalcitonin in the micro lab, there's going to be a good communication pathway between the chemistry lab, which is going to get that blood tube first, and then transfer it to the micro lab. But it absolutely has to be actionable. We have embedded in our computer system the interpretive analysis of that procalcitonin value, so the physician doesn't have to go look for the placard to see what 0.23 means versus less than 0.1. So that value is right on the screen. And again, you have to educate and continue to educate. It's very important to choose the correct procalcitonin. Again, we use it mainly as a test of exclusion in the emergency room or up on the floors. So we do use the Vitus Brahms procalcitonin, which was the only test used for all of the studies over the last 10 or 12 years. It's the only study that's FDA approved for this indication, and it's very sensitive at very low levels. One of the competitors, unfortunately, does not have sensitivity until 0.16 nanogram per mil. In our hospital, for a test of exclusion, that would eliminate at least 85% of my use for that value. So we're very happy with the Vitus Brahms Procal because we trust the fact that it gives us a sensitive reading for the LRTI patients. Potential barriers. Emergency room physician, they only have one exposure with the patient, right? So is there a policy in place at your institution where your emergency room clinician can follow up on his decision either to admit or not admit, or give antibiotics or not give antibiotics? It's difficult. Physicians and mid-level practitioners are very busy, so do they have the ability to see the outcomes of their decisions? So that's one of the barriers for implementation. And of course, we have the regulatory restrictions that impact decisions to follow a procalcitonin protocol. We know for sepsis, we have to give antibiotics within 3 hours of recognizing sepsis. Obviously, we're not going to wait for the Procal. If your patient is in septic shock, you're going to get antibiotics, and they're going to get it within 1 hour. But we know we have to meet that 3-hour requirement. And hospitals are penalized by CMS by withholding some payments if we exceed a readmission threshold for COPD. So obviously that is an issue. List of metrics. I wish it was easy, but it's not. It's continuously changing. It's very fluid. We'd love to decrease pharmacy expenditures for antibiotics. We know from all the studies that we can reduce antibiotics between 30 and 50%. If you're using less antibiotics, that's less checks you have to write. But, with all the drug shortages now, a lot of times we have to purchase antibiotics at much higher costs. And with some of the newer agents, we're talking $800 to $1,200 a day. So expenditures, if we lessen them, are nice, but there's too many confounders, and we really don't look at that. The C-suite does, but as clinicians, we are only interested in outcomes. We want to decrease antibiotic consumption. We know that daily defined doses is losing favor, and that we are looking at days of therapy. You have to make sure you're calculating days of therapy correctly. Otherwise, you're going to have an inflated days of therapy for certain antibiotics. Decreased length of stay is good, but there's too many confounders. We can get you off antibiotics, but if you're having trouble with your blood sugar, you're still going to be stuck in the hospital. And one of the things as far as decreased length of stay is we now have, thankfully, some robust studies that show that shorter courses of antibiotics are just as effective with less negative outcomes for disease states like UTIs, intra-abdominal skin structure, and LRTIs. You may see some people that say, well, that procalcitonin did not cause us to use less antibiotics. It was the new studies. But antibiotic stewardship is a village, and it takes a village. So you need all these robust, high evidence studies that prove that we can use shorter courses of antibiotics parlayed with procalcitonin, which is the trust factor in knowing that you can stop antibiotics. Mortality is always a dicey issue. Again, with all the confounders, we can get our ICU patient off antibiotics and off the ventilator, but if they're severely decompensated, it's going to be very difficult to change that mortality. But if we do look at mortality, we really have to just use same cause or same diagnosis and not all-cause mortality. And of course, readmission rates, that's probably the most important parameter that we use at our hospital. If we can prove that using shorter courses of antibiotics and decreasing length of stay results in no increase in readmission rates, then it's a win-win. And lastly, for stewardship, how do we define azithromycin? If your patient comes in with an acute exacerbation of COPD, they're going to get 5 days. They're going to get the infamous Z-Pack. Well, was that azithromycin an antibiotic, or was it an anti-inflammatory? And when you're collecting your data, you need to make that decision, because otherwise you're going to have a false elevation of antibiotic consumption. We know that from resistance that azithromycin is about 30% resistant against strep pneumo in the entire country, with a range of 25 to 45%. Basically ineffective against the usual pathogens that will truly cause a bacterial LRTI. So if we're using azithromycin as an immunomodulator or as an anti-inflammatory agent, we know that it has some data. We know that the data supports that you will increase the time between acute exacerbations, but at what cost? Right? We're using subtherapeutic concentrations of the drug, 250 milligrams Monday, Wednesday, and Friday, which unfortunately is going to breed more resistance, because whenever you use small doses of drug, getting back to that CDC thing, you're going to breed resistance easier. And of course, for long-term azithromycin, you have to have hearing checks, and you have to be treated or tested at least twice yearly for non-tuberculosis mycobacterium. So thank you very much, and I will pass this on to Michelle, our moderator, and be glad to answer anybody's questions.
Thank you, Dr. Boreyko, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window labeled Ask a Question, and click on the Send button. We will answer as many questions as time permits. All right, the first question is, would you withhold antibiotics on an LRTI patient presenting to the ED until you receive the initial PCP result?
Okay, that's actually a great question, and it depends on the patient, and it depends on your ER staff. At our institution, if you come in and you have an LRTI, but you don't know if it's CAP, the physician may order ceftriaxone azithro, but if the chest X-ray comes back, not clearly defining an infiltrate, we will recommend waiting for the procalcitonin before actually initiating the antibiotics. And in our institution, if we run at stat, we will have those results within 1 hour, so we don't affect waiting times in our emergency room. But that's a great question, and obviously, if your patient's decompensated, no, you're gonna give antibiotics, and because they need them.
Great, thank you. How many PCP tests would you typically run on a patient presenting to the ED with an LRTI during the flu season? That's an interesting question. We normally just get one, because if your chest X-ray is without infiltrate and your procalcitonin is negative, and if your PCR influenza is positive for A or B, we're just going to recommend treating for influenza. If your chest X-ray is a little spotty, we may order a repeat procalcitonin for the following day, just to make sure we don't have a developing bacterial pneumonia. Great, thank you. All right, this is a two-part question. So regarding the graph of the various biomarkers, does this illustrate a single exposure to bacterial infection and the respective time course? And if the bacterial infection is ongoing, do these biomarkers remain at the elevated level?
Okay, that's another good question. That is just a single exposure to the bacteria. We know with that single exposure, we get the cytokine and endotoxin response, which will stimulate procalcitonin production. We also know that if we don't initiate antibiotics, that procalcitonin will continue its climb. CRP may continue to climb, but we can't differentiate between a viral illness and a bacterial infection. And obviously, we need to make sure we have the correct antibiotics on board. So if you don't have the correct antibiotics on board, or you missed a site of infection, that procalcitonin should continue to increase.
Great, thank you. All right, your next question is, what level of procalcitonin do we expect in viral and bacterial infection? Can it be elevated?
The only time we would see it elevated is if the patient had some sort of renal disease or lung disease. Other than that, we've never seen an elevated procalcitonin in a viral illness.
Okay, your next question is, does it have a role in Mycobacterium tuberculosis infection?
At this point, it does not. There's ongoing studies to see if the availability of it would potentially help you do that. Again, we only get NTM testing in those who are on long-term immunosuppression or azithromycin therapy.
Great, thank you. Would there not also be an opportunity to personalize de-escalation in culture-positive patients, or even identify when the PCT is not decreasing despite antimicrobial management and support additional reassessment of the source control?
There would. Any antibiotic stewardship team can personalize this. Once in a critically ill patient, once we grow an organism, we tend not to get another procalcitonin, only because if you have appropriate therapy, if your patient has chleb-bacteremia and their procalcitonin is 13, we put them on 2 grams of ceftriaxone. The next day, they defervesce quickly. We don't even bother with surveillance cultures to see if they cleared their bloodstream for gram-negative, because that patient is already defervesced. They're doing fine. If for some reason they decompensate a couple days later, even though we have identification of the organisms, sensitivities, and MIC patterns, then it's almost the onus is on the clinician to rescan or reimage to see if we're missing a source of infection.
Great, thank you. What was the LOS data on inpatients with pneumonia on PCL monitored patients and those who did not have the PCL used?
Okay, I'm trying to wrap my head around this question. So I guess they're asking on inpatients with pneumonia. The only thing we can do is, again, there are 2 different cohorts, and if we did not utilize a Procal protocol, then we would compare that with the cohort that we did use the protocol in, and then you can compare the length of stay. Again, you would have to normalize that length of stay and get rid of any confounders that may have falsely increased your length of stay based on 1 or 2 or 3 other comorbidities.
Thank you. All right, your next question is PCT only used for LRTI or other types of infections?
Oh, well, I mean, we do use it for respiratory. We know it's highly effective in bloodstream infections. And a lot of times those bloodstream infections are incidental findings. You come in for a presumed pneumonia or even a UTI, and then all of a sudden your Procal is sky high, and sure enough, you have a bacterial infection. So we definitely use it. We've seen it also very positive for C. diff infections. The only thing we really don't see it being elevated is with UTIs. There's some anecdotal information out there that even in the absence of bacteremia, that Procal may be elevated in the UTI, but we need to get more data before we look at that.
Thank you. How would you schedule follow-up PCT testing when considering serial PCTs?
That would be the illness of the patient. So if we know you're septic, you're not responding to antibiotics, we would definitely get serial Procal. So, if you came into our emergency room at 4 p.m. and your Procal was moderately elevated, and then we put you on broad-spectrum antibiotics, we would probably schedule a Procal with the early morning labs. And hopefully it would be 50% of the first level, which means you got the right antibiotics on board and you probably haven't missed another source of infection. If you really are suspicious of the bacterial infection and the initial Procal is negative, they just may be a slow responder. And then I would not only do a serial, but probably one in 4 to 6 hours to see if it's gone up a little bit.
Thank you. All right, your next question is, do you include rapid respiratory viral panel testing in your ED-LRTI algorithm?
We do during influenza season. We are also implementing, hopefully this month or next month, a BioFire respiratory panel, which will help us in deciding whether or not we have a bacterial infection or a viral illness. But, you know, this time of month, no, we wouldn't get a viral except if it's from the CNS for aseptic viral meningitis.
Great. Thank you. We are receiving so many great questions right now. Let's see, your next question will be, how do CRP and PCT compare in bacterial infections?
I'm not sure if there's enough data for me to answer that question. Again, CRP isn't specific enough to rule in or out the bacterial infection. There's just too many autoimmune diseases or conditions like osteomyelitis or endocarditis that would also cause an increase in CRP levels. We actually just use CRP as a baseline and then as a response to therapy for our osteomyelitis patients.
Great, thank you. All right, your next question is, what was the stewardship team's role in the study? If involved, was it a 24/7 involvement? And have you considered utilizing BioFire combined with PCT-based stewardship?
Oh, absolutely. I mean, again, BioFire is just amazing, especially in the blood. It enables us to narrow therapy, oh my gosh, within 18 hours instead of the traditional 36 to 48 hours. If we combine that with the procalcitonin, again, the procalcitonin is the trust. It's the safety net for all of this. If your clinical suspicion is, I don't think this patient has an infection, and you get a negative procalcitonin level, that just reinforces your decision that you can probably withhold or immediately de-escalate antibiotics.
Thank you. Is PPT used for sepsis?
Oh, absolutely. Yeah. Again, the initial baseline, which we obtain in the emergency room, and then we'll definitely get serial procalcitonin level. So on day 2 and day 3, looking for that reduction. If day 2 is the same or elevated, then we really look at that patient much more closely, maybe change antibiotic regimens, or again, search for different sites of infection that we're obviously missing. Because if you're on broad-spectrum antibiotics and your procal continues to go up, you know, that's an issue of something is awry somewhere and we need to find it.
Great. Will procalcitonin levels be elevated for fungal infections?
We have not seen that yet. So we don't know. We know that fungal infections have beta-glucan and galactomannan as part of their cell wall. It's more of a cholesterol base. So at this point, I have not utilized procalcitonin for fungal infections. We're mainly in the beta-glucan galactomannan era for that rapid diagnostic.
Thank you. What is your laboratory's turnaround time for PCT results?
If we run it stat, it's within 1 hour. If we run it normally, it's a 4-hour turnaround time. So again, we don't ever impact the waiting room in the emergency room by keeping a bed occupied by somebody waiting for a procalcitonin level. And that just reinforces the fact that it's got to be actionable. If it's a send-out, that would be difficult at best, at least as a test of exclusion. If you can get it within 24 hours, it would be helpful for your septic patients. But if you're going to use it for a test of exclusion, you need to have that result within 1 or 2 hours so you don't impact the waiting room at the emergency department.
Great, thank you. What are some of the reasons to see false negatives for PCT levels?
We know for some atypical bacteria, mainly Mycobacterium and Chlamydia, because they're encapsulated, that they tend to not cause procalcitonin to elevate. That's not the issue with Legionella. If you have Legionella pneumophilia, you're going to have a markedly elevated procalcitonin.
Thank you. It looks like we have time for one more question. Would you recommend utilization of PCT would be meaningful for both CAP and HAP?
Yeah, it's always meaningful because it's that degree of trust that it gives you. For CAP patients, it helps us whether or not it's just viral CAP. I mean, if you look at the CDC EPIC trial, I mean, they used rather invasive sampling mechanisms, and they only grew an organism about 38% of the time, and the vast majority of those were viral. So in CAP, it definitely helps you whether or not you need to use antibiotics or not. HAP, it's a different story. Obviously, you've been in the hospital for 4 to 5 days or longer. You have to anticipate that. The respiratory event going on will be hospital-acquired bugs, which is going to introduce your drug-resistant Klebsiella, your Pseudomonas, and your Staph aureus. So procalcitonin would definitely be beneficial because if you were growing one of those bugs, it would be markedly elevated.
I would like to once again thank Dr. Boreyko for his presentation. Do you have any final comments for our audience?
I do. I mean, embrace procalcitonin. It's part of, and I think it's an integral part of antibiotic stewardship. You need to adjudicate hundreds of procals before you really get a good trust, and that's both infectious disease physicians and pharmacists, antibiotic stewardship teams, and the clinicians. The more procalcitonins that you look at and you see that the outcomes were better and that there were no adverse reactions from withholding antibiotics, the more you trust the test. It's all about trust. You absolutely have to involve all the players, and once they trust the test, then it's a valuable component of any stewardship program.
Thank you. I'd like to thank the audience for joining us today and for their interesting questions. Any questions we did not have time for today will be addressed by the speaker via the contact information that you provided at the time of registration. We would also like to thank our sponsor, bioMérieux, for underwriting today's educational webcast. Until next time, goodbye.